Osteotomy, there's Alberto receiving his distinguished acknowledgement from the SRS this year. This osteotomy was first described in 1987 by Alberto Ponte of Italy, and it's really a wider resection than a Smith-Peterson, who described his osteotomy for a fused spine. This is for a mobile spine. And he wrote an article this year that you should read about his view on the osteotomy. The theory of this osteotomy is it creates a space in the posterior column to allow cantilever of the spine in kyphosis beyond its natural resting state, or shortening for kyphosis, which is what the osteotomy was described for initially. The axis of rotation in extension rotates posteriorly with this, and it qualifies as a Schwab type 2 osteotomy. It can be used in kyphosis, which he described it for, eliminating the need for an anterior release by posterior column shortening. It can also be used in scoliosis, especially the lanky type 5s, where you do it at every level to save levels, or other types of deformity, which you can sometimes save a level by getting more correction within the defined segments, often done asymmetrically. Which levels need pontes? In kyphosis, it should be all those with an elongated lamina, all that have a wedged vertebra, and that don't correct in hyperextension. In scoliosis, it can be cob to cob for the short, lanky 5 fusions, or the apical rigid segment for the main thoracic curves, or those with lordotic segments. The risks, however, are that you do create a bit more blood loss by entering the canal at various levels, and Matt Helansky estimated about 30 cc's per segment. It takes more time. And there may be some more neuromuscular alerts according to some series. However, there is not a documented increased risk of neurodeficit. I'm sure there is some degree of risk, and there's a relatively short learning curve. The tools needed include rongeurs, either Lexcel or Kerrison's, harmonic scalpel, or burr in some cases. So the steps are listed here: clearing the soft tissues, removing the spinous process, excising the inferior facet, then the superior facet, and the ligament flavum. So step 1 involves removing all the soft tissues, including the pericapsular attachments, which may tend to bleed when the facets are resected. I also do my osteotomies before pedicle screws are inserted because I think it's easier and safer to work around the canal when there are not more obstacles sticking up. Step 2 is to shorten the spinous process in the base of the lamina. According to the green lines you can see here, you're trying to take some length out of the posterior column. So looking from the side and looking from the top, that's about how much you want to take out. It can be wider on the convex side of a scoliosis. And you can perform it either with a rongeur or a bone scalpel. I like to add bone wax if necessary because these are often a source of bleeding that's hard to control. Step 2 is to remove the inferior articular process of the top segment, which defines your working space and the amount that you can shorten the column if necessary if you're doing a kyphosis corrected. And this is done a little bit more differently in the thoracic spine than the lumbar spine, either with a bone scalpel or with a rongeur, as you can see in the bottom segment. Take a wide piece out of that. Then you remove the superior articular process of the level below, which is more likely to bleed. In the convex side or the kyphosis side, you want to remove that segment. In the concave side, you may just incise it to allow a manipulation. Here you can see on the left side done with a bone scalpel. On the right side, I like to use a Kerrison, but coming from the lateral to the medial side, so you're not in the canal yet. You're staying outside the spinal canal while still doing the bony shortening and resection. And then finally, the ligamentum flavum resection is done often after the instrumentation is in, and this allows it's important for kyphosis correction so you don't have infolding, and it's also important for scoliosis to get some lordosis in some of those cases. Working with the pontes, you then control the bleeding with flow seal and gel foam, but you have to be careful at this point because it's different than we used to have. We have a canal that's open in multiple places, and instruments love to go there, so you have to be very protective about who's working around the canal and have excellent control at all times because you're putting a very healthy patient at a slight degree of increased risk. Screw insertion then comes after the ponte osteotomies, and you can see that with appropriate rod contouring and choice of anchors, you can create more kyphosis in a lordotic spine. Peter Newton has shown us how much lordosis there is in these spines, and once you straighten them out, you have to avoid creating more. So here are some of the things you can do with the ponte. In the old days, you used to have to do an anterior release, but now you can shorten the posterior column and correct a significant kyphosis, or correct a thoracic lordosis with fewer segments than we would otherwise have had to use. So Dr. Ponte says this is a powerful tool, but you have to use it wisely and only when needed, and be careful about the increased bleeding and the increased neurologic risks with this multiply open spinal canal. Thank you.